Welcome to Equity, Structural Racism, and Public Health Law. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum with my colleague, Jeff Bornstein. Thank you to our partners for today's event, the Centers for Disease Control and Prevention's Public Health Law Program, and the Center for Health Leadership and Practice. And now it is time to meet the moderator of today's event, Dr. Carmen Rita Nevares. Dr. Nevares is the Public Health Institute's Senior Vice President of External Relations and Preventive Medicine and the Director of Dialogue for Health. She's also the Director of the Center for Health Leadership and Practice, which runs the National Leadership Academy for the Public's Health. And welcome, Carmen.
Thank you so much, Merlene, and welcome to our audience. We're really excited to have this meeting today. Last year, we had brought some experts from the Centers for Disease Control and Prevention to this audience to share their work and advice about understanding how to address equity and structural racism using public health law. This conversation was highly successful, bringing one of the largest Dialogue for Health audiences to participate. We're thrilled to bring these very same accomplished speakers back today to engage in an updated conversation about these important issues. I'm also happy to announce that for those who need it, a certificate of participation is now available if you listen to this web forum. A day after today's event, you'll receive an email link with a link to the certificate. You may download that link and fill in your name and maintain the certificate for your files or share as appropriate. So let's start with a poll. Let's see the poll. How knowledgeable do you consider yourself about the relationship between law and health and equity in health? Please just take a moment to fill out and answer whether you feel that you're extremely knowledgeable, moderately, somewhat, or not at all knowledgeable in this area. This just helps us to understand who's in our audience today. So I'm really pleased to introduce our speakers to you, after which we'll go back and take a quick look at the slide results, at the poll results, and then we'll go launch straight into the presentations. First, we're going to hear from Matthew Penn, who's Director of the Public Health Law Program at the Center for the State, Tribal, Local, and Territorial Support at the Center for Disease Control. In his role as the director, he leads a team of legal analysts responsible for the agency's efforts in legal epidemiology and workforce development to support the understanding and use of law as a public health tool at the state, tribal, local, and territorial levels. Next slide. Following Mr. Penn, we will hear from Sam Bent-Weber, who is a public health analyst for health equity and law at the Public Health Law Program. She specializes in work to improve public health through the development of legal tools for the provision of legal technical assistance to state, tribal, local, and territorial governments, as well as public health officials within the CDC. She has her JD from Harvard Law School and bachelor's from Harvard College in social studies and African American studies, and also has completed a postdoc fellowship within the Satcher Health Leadership Institute at the Morehouse School of Medicine. So with that very excellent background, in a moment we'll launch into their presentations, and I just want to ask Jeff to bring up the poll for us. Okay, so the audience is somewhat familiar with this area, and so hopefully by the end of today's webinar, we'll all feel a little bit more firmly seated in our understanding and probably have a ton of questions to answer, to ask our panelists to answer at the end. So please use the Q&A freely to throw in your comments and your questions, whatever you'd like us to get to by the end of the presentations. Okay, Matthew, would you like to start?
Great, thanks so much, Carmen. And also a big thank you to the Leadership Academy in this year's cohort, and also to the Center for health leadership and practice, all the folks behind the scenes helping us put this on today. And welcome everyone, and thank you so much for spending some time with us today. And we're going to be talking about using law to advance health equity. Next slide, please. So Sam and I have three sections to our presentation. A case study to look at what structural inequities can look like in a community, an introduction to structural racism and other inequities. And finally, Sam will talk about how law can be used as a tool for advancing health equity. Next slide, please. So these materials are for instructional and educational purposes only. They do not represent the official position of the agency, are not meant to provide legal advice to you or your health department or whatever agency you work for. And while Sam and I are both licensed attorneys, we're not your attorney. And if you should need legal advice, please seek advice from an attorney authorized to provide you or your agency a representation. Next slide, please. So first, we'll do a look at a little case study here. And our case study centers on the question of what can the role of public health be when faced with communities' fundamental needs and systemic and structural inequities. Next slide. So imagine that you live in a small city called Zanesville, Ohio, located in the southeastern part of the state in the Appalachian foothills. Your community, referred to by the name of the road on which most residents live, Coal Run, is a tiny, majority Black and located a few miles outside of the city center. Next slide. This small city and its surrounding county is the site of a formerly robust but diminishing mining industry. The Coal Run community sits atop long abandoned coal mines that left behind pollution that contaminated the groundwater. As a result, residents cannot rely on their wells for safe drinking water. The water corrodes, clogs, or destroys everything it touches. And as you can imagine, if it's corroding and clogging and ruining plumbing systems, what it could do to the human body. Next slide, please. As a result, residents of Coal Run have had to rely on alternative methods to obtain safe drinking water from cooking, drinking, and bathing. One of your neighbors reports that as a child, his parents would fill their bathtub and not change the water until 5 of the 10 children in the family bathed in order to conserve the water trucked into their cistern. Another reports that he only does laundry when it rains. Many in the community purchase water from a nearby water treatment plant, spending up to 10 times more than those people in your area who have access to the public water system. Others have reported physical ailments and illnesses as a result of having poor water access. Next slide, please. Between 1954 and 2002, residents of the Coal Run community undertook efforts to obtain access to public water administered by the city of Zanesville or Muskingum County. Until 2002, most residents still used outhouses. And I would ask you for just 1 second to think about where you were living in 2002 and what your living conditions were and whether or not you were using an outhouse. Next slide, please. So these efforts by the Coal Run community, these lobbying efforts, fell on deaf ears. One county commissioner told you and your neighbors that you would not get water, quote, until President Bush dropped spiral bombs, end quote, in the community, and they hit good water. The same commissioner said the community members' great-grandchildren would be lucky, quote, lucky, to have running water. This is under President Bush, not that long ago. One neighbor contacted the public health department and was told to, quote, dig a well. Understanding the community sits on top of abandoned coal mines that had polluted the groundwater and making it unusable. Next slide, please. So as you can see from this map, documenting water lines throughout the county, residents should not have to dig wells. Coal Run, represented here. If you look here, I know you can't see my cursor, but I'm using the cursor. If you look sort of towards the center of the slide, that blue area there, that blue patch, that's the Coal Run community. And as you can see by these blue lines that represent the water lines, Coal Run was surrounded by public drinking water lines. So let's just sit with this map for a moment. This majority Black community did not have water lines. And yet here's the water treatment plant right here, this little triangle. It's not that far away. And yet through implementation of laws and policies and the public water system, they were able to run water lines clear out to the east, well over 5 miles, probably 10 miles out. Down to the southeast, another 10 miles. Further to the southeast, another 10, actually extending beyond the map. Waterline distribution here, just on this sort of northeastern border of the city of Zanesville. You see those dark blue patches. Those are water lines that are so concentrated, you can't even make out the individual lines at this scale. Water lines everywhere, but not in the Coal Run community. The next slide, please. About 85% of the Coal Run residents were Black. It was one of the few and possibly the only majority Black community in this county. Notably, in 2002, the county was 94% white and about 4% Black. And the county's demographics have not changed much since then. After trying to get public water lines for almost 50 years, Coal Run residents filed a complaint with the Ohio Civil Rights Commission in 2002, asserting, quote, a pattern and practice of discrimination that violated federal fair housing laws. The commission in turn conducted an investigation and found evidence that the race of the Coal Run residents was a factor in the decision not to run water to the area. That's 1954 to 2002. Let's just sit with this map for a moment. You can see over towards the left-hand side of the screen in the city of Zanesville, the water treatment plant. The water line runs directly to the east, a little bit south, and then runs right down Adamsville Road and out into that larger map that you saw on the last slide. Even takes a right-hand turn onto Langan Lane, serving, if you notice the colors of the houses here, serving the white portion of the Coal Run, this neighborhood here, and stops right as the neighborhood becomes predominantly African American. And if you look at the scale here, we're talking about tenths of miles. It's a very, very short distance. And from my experience in working at the intersection of public health and public utilities on a number of occasions in my past practice in South Carolina, tenths of miles are very, very short when it comes to public utilities, running sewer, running water, running electric lines. We're talking about sewer lines that in some cases run tens and tens and tens of miles from treatment plants. Pumps are installed to counteract gravity in order to move water and to move sewage. So this is a very short distance. And of course, as you would drive down as one of the persons who lives in Coal Run neighborhood, you could drive up Langan Lane over to Adamsville Road, coming out of your neighborhood. And as you go by, you could see your neighbors, your white neighbors, filling their swimming pools, running their sprinklers, maybe have a little splash, one of those little slip and slides with the kids out in the front yard, understanding that your neighborhood has not had running water for 50 years. Next slide, please. So what does our case study tell us about the relationship among racism and other inequities, public health, and law? Next slide. This story is about a number of overlapping issues. It's about racism and how the water line stopped where the Black community started. It's about intersectionality and how the inequities extended beyond the Black community of Coal Run and into other communities because of where they lived and possibly their poverty. It's about law, and it's about expanding how we see public health and the work that we do. And ultimately, It's really about equity and justice and about using the power and the tools that we have in our communities to make a difference. Next slide, please. Coal Run was one of the few and possibly only Black majority communities in the county, as I said before. So let's be very, very clear about this as we approach these issues. The Coal Run story is about racism. This is what racism looks like. The Coal Run story helps us to better understand how racism can be structural and systematic. It's not merely about individual hostility or grievance, although in this case, there may have been instances of that. But rather, it's about the ways that legal principles, policies, and practices work together to disadvantage some people on account of their phenotype, traits, physical characteristics. And another point to be clear about, in this instance, the community was not subjected to laws and policies that explicitly discriminated against them. Instead, they were subjected to water laws that appeared to apply to all people in the community equally. But as we saw from the maps, the application and the implementation of those laws were in effect very discriminatory and about something as basic as turning on your tap and getting water. I've probably done a dozen times today. I got my little cup of tea. I went down while we were in the green room, made myself a cup of tea, and I got the water out of the tap from a public water line. Next slide, please. In public health, as in much of our broader society, we reached an important moment in our discussion about racism. We are moving beyond a conversation about racism as simply a collection of the individual actions of morally flawed exceptions operating outside the norms of society. This idea that yes, racism happens, but then everything goes back to normal. That just doesn't exist. Instead, we're moving towards a more comprehensive discussion about racism as a system of structures, practices, policies, and norms that create and sustain social, economic, and other conditions that shape well-being and life chances for specific populations. Next slide. When Coal Run filed their complaint, the county was approximately 96% white. At the same time, more than 32,000 other families in the county lacked access to running water. While racism might have had a hand in shaping the Coal Run community's access to water, many other people elsewhere in the county, the overwhelming majority of whom were white, lacked access to running water, likely because of other factors, such as socioeconomic status, rurality, geography, and maybe even lacking a civic voice, or feeling like they didn't have a civic voice. This is that intersectionality. In 2002, when the Coal Run community began to ramp up their efforts to obtain water, median household income in the county was only about $35,000. So we start to see this intersection of race, poverty, rural circumstances, community voices conspiring to deprive people of a very fundamental life necessity, water. Next slide, please. These forms of disadvantage arise from the many conditions in which people live, which we refer to in public health as the social determinants of health. Public health dimension of the Coal Run story draws our attention to the social determinants of health, the structural, economic, cultural, and political factors that order relationships, assign social status to members of different populations, distribute money, distribute power and other resources, and build or disrupt communities. In the case of Coal Run, the social determinants concerned their standing within the community as Black residents, but also the complicated infrastructure that allocates water across communities, the socioeconomic conditions of the community resulting from the loss of the coal mining industry, and the environmental degradation that, of course, resulted from the mining and affected the groundwater. So from the health department, dig a well, it simply was not possible. You dig a well, you're going to get bad water. That wasn't the solution. Next slide, please. Coal Run residents filed a complaint with the Ohio Civil Rights Commission in 2002, as I stated, asserting a pattern of practice of discrimination that violated federal discrimination laws. The commission found evidence that the race was a factor. But part of the problem that we face now is that racism is often invisible or difficult to identify because it's embedded in law. Statutes, regulations, rules, policies, implementation practices, and judicial opinions are what drive our legal system. And they really drive much of how our society operates. Historically, many of these legal norms were overtly and intentionally racist. And we talk about those. And I think from my experience, having gone through law school and worked in law for 20 years, I think it's easy for us to sort of look at those. And again, look at those as aberrations and things that we've gotten past and gotten beyond. And that, oh, that was racist. And now everything is back to normal. And these would target specific populations because of their race or ethnicity. But as we discussed earlier, legal norms can be neutral on their face and need not be expressly racist to have a disproportionate impact on communities of color. Next slide, please. So just as law is a system of rules, policies, and practices that can create disadvantage, it's also imperative to transforming those conditions of disadvantage. Law plays a central role in achieving two ends. It can profoundly shape the context in which people live to increase their access to the things that they need and to make it easier for them to make decisions about their health. And law has the power to redistribute resources to make the things that people need to live healthful lives more accessible. In this case, we saw how a legal intervention, filing a discrimination complaint with the Civil Rights Commission, was necessary for their health. But sometimes that kind of legal intervention may not be the best approach because they take a long time, they're money intensive, or because it can be narrow adversarial proceedings, not in the best interest of the community. So it begs the question, like, how would the community, the town, the county, the state even, like how would they have changed if they had taken a different approach in 1954 or 1964 or 1974 or 1984 or 1994, right? It gives you a sense of how long that progression is, decades and decades of inaction. Next slide. So public health gives us, the public health approach kind of gives us a different approach. And we can draw upon existing approaches such as the 10 essential public health services and Healthy People 2030 that put health equity at the center of public health practice. But from the quote here, a focus on health equity may entail venturing beyond our boundaries in public health practice to matters intimately linked to health disparities such as housing, labor market, or employment conditions, civic participation, and forms of discrimination. Whether we're in public health or healthcare or other sectors, we will have to go beyond documenting disparities and identifying and focus on key interventions, facilitating collaboration across sectors and disciplines and areas of expertise, and identify law and policy solutions rooted in science. Next slide, please. But if this is the direction we're going towards advancing and ultimately achieving health equity, particularly among people who've been disadvantaged because of racism, what does that mean exactly? Health equity is when everyone has the opportunity to be as healthy as possible, to reach their full potential, and importantly, when we bring racism into the discussion, it is when no one is disadvantaged from reaching this potential because of socially determined circumstances, such as race. Health inequities are the result of African, Asian, Arab, Hispanic Americans, as well as American Indian and Native Alaskans, and many others, being denied the opportunity to achieve their full potential because of systemic racism. But as we've stated, racism is also entangled with other social forces like sexism, geographic isolation, economic and political marginalization, and others that sap the strength and good health and well-being of our entire society. This is not a zero-sum game. Studies have shown this. Achieving health equity will require us to disentangle these forces and to employ a number of strategies to do so. So my colleague, Sam, will now speak to some of the thinking we've been having here at CDC and the Public Health Law Program about how public health and law can play a role in disentangling some of these forces. Next slide, please.
Thank you, Matthew. So we highlight the Coal Run story, not only because it helps us to understand how structural racism operates, but also because it points to the relationship between public health and law, particularly for addressing health inequities. As Matthew highlighted, the Coal Run community faced a serious public health problem. They needed and struggled for decades to obtain affordable access to clean and safe water. In this instance, they were able to get access to that water by using legal strategies that exist outside of traditional public health practice. And Matthew has provided you with a high-level overview of the problem, that racism and other forms of structural and systemic inequity are embedded in law. And historically, they were built into the language of law and policies and judicial opinions, but over time, they've become embedded in the application and implementation and enforcement of laws and policies. And all of this, as Matthew has alluded to, raises the question, which is, what is the role of public health in addressing these real, concrete health equity challenges? And so from our perspective, an important starting point to answering this question is recognizing and applying the relationship between public health and law, like really centralizing that relationship and bringing the law into public health practice. The law is not something that lives over there, that's done by lawyers, but is done by all kinds of public health practitioners and, frankly, all kinds of citizens. In our view, it is critical to advancing not only public health practice, but also equity, which is, and this sort of connection of ideas is at the center of the 10 essential public health services, which we'll talk about in a few minutes. Next slide, please. So at CDC, we're working to develop frameworks and strategic approaches to addressing health inequities by recognizing the impact of structural racism and other structural and systemic factors on public health outcomes, and by extension, in public health work. Next slide, please. So while we're recognizing that it's important to identify and document health disparities, right, because that work has become a really important part of public health practice, doing research, gathering data, gathering information, understanding the health landscape. We are also acknowledging that it's not enough to simply name the problem. Rather, we are emphasizing the significance of root causes by engaging in the collection and analysis of data that helps us to better understand the social conditions, or what Matthew alluded to as the social determinants of health that give rise to health disparities. We are recognizing the importance of providing context for why some populations experience poorer health outcomes than others. And importantly, we also can apply some of this thinking to recognizing why, as a nation, we experience poor health outcomes across the board, particularly in relation to comparable societies elsewhere in the world. And so correspondingly, in developing these frameworks and strategies that move beyond documenting disparities, we are centralizing the importance of policy and health interventions that can facilitate change and ultimately improve health for more people. And in so doing, these strategies and frameworks recognize, as Matthew emphasized earlier, the potential necessity of focusing our research and policy priorities on topical areas that may exist outside of what we might call traditional public health boundaries, into domains like discrimination or employment or housing or labor market conditions. And so this means focusing on policy solutions that are rooted in science and rely upon contextualized data and information. And I'm going to add more clarity, I hope, about what I mean by contextualized data. Next slide, please. And so we have some precedent for some of these approaches. In 2020, with the support of CDC, the de Beaumont Foundation and the Public Health National Center for Innovations updated the 10 essential public health services. These have been characterized as describing the public health activities that all communities should undertake. So I'd invite you to take a look at the image on the left side of your screen. And so let's note some important elements of this revised and updated framework. This framework has been around since about 1994. And it really has meant to serve as a sort of guidance framework for public health practice and community health practice. Now, as a starting point for the most recent iteration of this framework, it places equity at the center, not health equity. And the reason for that is to emphasize the fundamental importance of equity to public health practice. And from our perspective, it also emphasizes that in order to maximize the health of all people in all communities, we have to center equity, not just in health, but in all aspects of life and in all institutions and practices and social conditions that have an impact on all aspects of life. And to that end, I just want to quote a little bit of language that we put together in we being the CDC, about the essential public health services and sort of what it's aiming for. To achieve equity, the essential public health services actively promote policies, systems, and overall community conditions that enable optimal health for all and seek to remove systemic and structural barriers that have resulted in health inequities. These barriers include poverty, racism, gender discrimination, ableism, and other forms of oppression. Everyone should have a fair and just opportunity to achieve optimal health and well-being. But by placing equity at the center, this framework recognizes that to achieve that optimal health and well-being, we have to focus on all systems, all structures that govern life. And so I just want to also highlight the Healthy People 2030 framework that's on the right side of the screen. And that's meant to emphasize again what we've referenced several times now throughout the presentation, the social determinants of health, and that there's a connection between these social determinants, namely those conditions that I've highlighted, and these aims that are set out in the 10 essential public health services. Next slide, please. And so these frameworks that are in play both within CDC and elsewhere in public health practice, like the 10 essential public health services, recognize the importance of law for improving health and well-being of all people. And so you'll note on the right-hand side of this sort of road to health equity that policy, which encompasses law and regulations and rules to improve population health, but also the strategies for implementing and executing laws and regulations and rules that affect population health. Next slide, please. And so from our perspective, the question becomes, well, what does this mean? How does this role of law play out in the context of public health practice? Matthew and I have noted that law has contributed substantially to inequities in health. Racism and other forms of inequity are embedded in our laws, our policies, and our practices that execute and enforce laws, and in the systems that arise from them, all of which have undermined public health and well-being. And at the same time, law has been essential to improving public health. Indeed, many of us know about the important role that law has played in promoting public health by helping to mandate seatbelt usage, by establishing and maintaining federal clean air and clean water and toxic substances laws that started to get developed and implemented in the 1970s and onward, by imposing food safety standards and labeling requirements. All of those developments in public health have a deep connection to law and to efforts to update and invite law into public health practice. And so in this way, law is a determinant of health. It's something that is increasingly emphasized in public health conversations, but I just want to emphasize it again here for our purposes. Law is a determinant of health. It's fundamental, it's foundational, it contributes to the root causes of health. And so with this awareness in mind, we are asking how law can help us to achieve equity, and how can public health practitioners in particular, whether they're lawyers or not, draw upon law as a set of ideas, a set of rules, a set of policies, a set of practices that can help us to promote and advance and achieve health equity. Next slide, please. So from our perspective, we propose that law fits into public health practice in a number of really critical and crucial ways, some of which that we don't identify here, but that can help us to develop public health strategies for addressing health inequities. In addition to being a determinant of health, law is something that can be studied, not just by reading case books or reading court opinions, but we can actually study and trace and understand the relationship between law and health outcomes. We can look at the language and the implementing rules and the elements of statutes and regulations and rules and even judicial opinions and guidance documents, and we can better understand how those specific elements might have an impact and have implications for health outcomes. In addition to that, so let me just highlight here that when we talk about law as something that can be studied, one of the things that we emphasize within the public health law program and within our work and our practice is a study of legal epidemiology, which is a systematic approach to studying law in order to assess its impact on health. In addition to the sort of research and translation piece that fits into public health practice and that can incorporate law, we can see law as something that can be centralized in our efforts to disseminate that research and to build capacity among public health practitioners. I just want to highlight the language that's quoted on this slide. It's from Derek Bell. He's actually quoting another scholar, Allison Anderson, who wrote in this essay called Lawyering in the Classroom. A lawyer's primary task is translating human stories into legal stories and retranslating legal story endings into solutions to human problems. You could actually make the same case that is precisely the same task of public health practitioners. And so if we think about the role of public health practitioners in storytelling, in talking about the experiences of human beings who encounter public health challenges and who encounter public health challenges that have legal foundations and origins and roots, then we can also think about how public health practitioners themselves, not just lawyers, but public health practitioners themselves, can translate those stories into solutions to public health problems. We think about these efforts in the context of legal advocacy, but they can be a critical element of public health approaches to discussing and highlighting and emphasizing intractable injustices and inequities that impact health and are frequently connected to laws and policies. Finally, and the last piece of this is that law is something that can be a central part of efforts for collaboration and partnership and policymaking. It's foundational and fundamental in the effort to identify policy solutions, right? And what it does is if public health practitioners and community members who are trying to address public health problems can think about law as something that can expand their potential universe of collaborators and partners, as something that can be focused upon and addressed, then that can sort of shape in really concrete ways how public health practitioners and ordinary people working on public health problems can address those problems. Next slide, please. And so just to reiterate this point about the study of law, again, in public health, we focus a lot on data and we focus a lot on the collection of data. And that has not changed, particularly in our current moment, and particularly as we think and look forward about how we can better understand disparities in those populations and communities that are disparately affected by health inequities and by systemic and structural inequities. We think about the fact that law can be a source of data. We can trace the relationship between racism and other forms of inequity and laws and health outcomes. We can do that through legal epidemiology. We can do that through other forms of public health law research. And in so doing, we can better identify the root causes and sources of inequitable outcomes. We can provide better context for disparities that we see. And that's really crucial, because when you provide context, what you do is you take the disparities out, not just, you take the disparities out of the hands of the populations that are experiencing them, and you make them a part of the larger structure, the larger society that we live in. It becomes a problem that we all must confront. Next slide, please. Law can also be leveraged to help us to tell richer stories about the relationship between law and health outcomes. So that is also a fundamental reason why we focused on the Coal Run case here today. By telling the story of this community that had a fundamentally and profound public health problem, but focusing it through the lens of it as a legal problem, we can sort of make the connections between law and health outcomes and structures and systems of inequity and health disparities. By studying laws and their impacts on health, and then by identifying communities and populations that are impacted by those laws, we can trace the sources of inequities, and then we can better articulate why those inequities are a problem. In so doing, we can also identify and hopefully mobilize better policy interventions. Next slide, please. To that end, with all of these themes in mind, I just want to introduce our pathway for public health law and health equity. We'll be discussing this in greater detail in the next sort of segment of this presentation. So stay tuned, but I just want to introduce it and highlight some of these crucial elements and sort of reiterate some of the themes that we've talked about here today. This is meant to be a real pathway, right? A way for public health practitioners and communities of practice to sort of move toward addressing health equities, but by invoking and bringing law into their work, into their study of inequities, into their brainstorming about how to resolve inequities, into their efforts to translate and disseminate messaging about inequities, and into their efforts to develop strategies for change. So just briefly, I want to highlight these elements. So from our perspective, the pathway includes highlighting and identifying local health equity challenges and the sources of those challenges, which are frequently but not always community-centered. We want to again designate and emphasize the fact that law is a determinant of health. So when we're thinking about the factors that have an impact on health, our foundational principle is that law is a determinant of health. As such, law can be studied, and its impact on health outcomes can also be studied. That sort of relationship between law and health can be studied and traced. And we can use that assessment and analysis, and also the idea of law itself as a way of talking about and narrating and disseminating messages about inequities and their fundamental root causes and their sources and the ways that they have impacts on people's health. And we can develop strategies for change by placing law as a focal feature in the effort to address these equity challenges. So with all of these themes in mind, I just want to note that we're trying to think in concrete ways about how to build some steps into public health practice and to sort of concretize those 10 essential public health services and concretize the sort of policy and law elements of those services. Now, I just also want to note that this pathway is meant to be a work in progress. It is connected to much of the concrete work we're doing within the public health law program and elsewhere in CDC, and it's really a starting point. And so I'd like to also invite comments and reflections and questions about some of these elements as well. I'm going to stop there, and I think we have time for questions and answers now, right?
We do. Thank you so much. And let me just sum up my own thoughts by saying that I think that the two of you have packed a huge amount of information and opportunity for thoughts and reflections from the audience. I'm going to get to a couple of the questions that were asked from the audience. I do encourage everybody who has a question or a comment to please use the Q&A and get those in there. We're going to incorporate this. We have another good chunk of time in which to sort of draw out some of these thoughts. Let me just start by going back to the Coal Run case study for a moment and ask, I see that the resolution and redress finally came by going to the State Civil Rights Commission. Talk a little bit about why that particular legal remedy was chosen and why is it successful in this case?
So the reason the community ended up going to the Civil Rights Commission is a little bit of a, it's a complex mix, right? So we see that for about 48 years, the community members made a number of efforts. They lived in a small place. They knew their public leadership. They knew their policymakers. And so they lobbied them directly. They reached out to them. They talked to them. Some of them they knew as neighbors. And that didn't work. And as it turned out, one of the local public officials sort of nudged the community members and said, actually, let me back up for just one moment. I should say that there were steps taken by some policymakers to try to make efforts to get the water issues addressed. Some sought estimates for how much it would cost to get a water line run to the Coal Run community. Others tried to kind of build connections within the county commission and to try to, sort of build momentum, to mobilize some efforts to get the water lines going. And those efforts were unsuccessful. And so ultimately, sort of in around 2002, the community members, one of the members of the community got a little nudge from a local policymaker who said, you may think about filing a complaint with the Civil Rights Commission. And so it was just sort of a word of mouth source of advice, and the community decided to pursue it. And when they presented their stories and the information that they had, the Civil Rights Commission said, you've got a potentially strong case here for discrimination, so we're going to move forward.
So this is really something where the community did the organizing and did the nudge and then handed over the redress to a body in government to solve the problem.
Yes, but a number of other factors were at play. So After the sort of case in the Civil Rights Commission built some momentum, local political leaders and policymakers decided, you know what, there's something here and we need to resolve this issue. So the complaint didn't actually make its way through a full adjudicatory process. Local policymakers and even all the way up to the governor sort of said, okay, let's do something here. We've got to take some initiative here. And they figured it out within a year and a couple of months after filing the civil rights complaint. The community members got water. And so it's a mixture of a legal process and community advocacy and a political process. The other interesting piece of the story is that once their civil rights complaint was sort of resolved, right? They got access to water. The community decided we're going to seek civil damages for all of the years, the 50 years, almost 50 years that we have been lobbying for access to water. And so they pursued a discrimination case in federal court because they wanted to make a statement about the impact of that kind of discrimination on communities like theirs. They wanted to set a precedent.
So can you also, maybe using this example, talk a little bit about some of the other strategies that might be employed by a community in order to seek a solution that are in addition to filing a lawsuit that would depend upon the knowledge of sort of this body of knowledge that you've just brought to us?
So that's a great question. I think for me, I was an attorney for the state public health department in South Carolina for many years before coming to CDC. And for me, one of the interesting things about Coal Run and why I think it's so engaging as a case study is I saw Coal Run in retrospect in my community. I didn't see it when I was practicing. I was a frontline public health practitioner. I represented the county health departments in South Carolina. I represented the state health department in South Carolina. I represented the Division of Water Protection. I represented the Environmental Health Division that did septic tanks. I lobbied the state legislature for money, large sums of money, to run sewer lines to a neighborhood where the health department had made a mistake. I was part of the team counseling our health commissioner on a community where their community well was corroding the lead pipes inside their houses, a predominantly African-American neighborhood. And our stance at the health department was, that's not our job. The pipes inside your home are not our responsibility. That community water system is not our responsibility. Now, ultimately, redress was found, but the initial stance was exactly as it was in Zanesville with Coal Run. And I was a party to that. So this is not, it is about Coal Run, it is about Zanesville, but it's also not. It's about all of us. You're surrounded by water lines all the time, and you're definitely surrounded by people who need water all the time. So I think having a better understanding now of the alternatives, I think what Coal Run points to is we can use public health to track disparities. The public health department didn't even go to the neighborhood, as far as we know, and see if the people were getting sick because of the water. The public health department could have used its power to convene cross-sector. When I was helping this one neighborhood get sewer lines, I was talking to mostly people who didn't work at the health department. As the representative of the health department, I was working with the public utility up in the city that served that area. I was talking to the community members. I was talking to the developer who put the roads in and was building the houses. I was talking to the state legislature. I was talking to lobbyists. I was talking to appropriators with the state. I was working across sectors to try to find a solution. And I think that's what we can do now. We can go out, we can study, we can test, we can track, and we can advocate for the health, right? We get so afraid in public health of advocating. We never really are advocates for health. There's nothing wrong with that. That is the job, actually. And it runs through the 10 essential public health services. So they can advocate, they can speak on behalf of, we can hold meetings, right? We have at least some resources. We can hold meetings. We have a title and names, if nothing else. We can bring people together in open discussions and say, hey, this is a health issue. Our job's health. This is a health issue. Can you come and help me out here? And I think, that's part of what that public health approach kind of gives us a different way. And we can tie it to academic this, academic that, public health 3.0, tie it to our pathway. But in the end, the health of our communities really is our responsibilities. And I'm talking to everybody. It's not just whether you work at a public health department, you work for a hospital system. The health of your community is your responsibility. That's why you're in the business. If you work in local government, the health and safety and well-being of your constituents is your job. And that's all the constituents. And when I look back on my experience as an advocate, as a representative of a government agency, I didn't see, that's why I can sympathize with the people in Coal Run. I can also sympathize with the people in the health department. I didn't see it. I didn't know enough. I hadn't matured enough. I hadn't evolved enough. I didn't see the racial component to it. I didn't see my part in that discriminatory practice. I didn't see my complete blindness to whatever inequities were around that neighborhood I was trying to get sewer to. However many neighborhoods around that didn't have sewer, didn't have running water, didn't have public water, that could have. So to me, that's a powerful part of what Coal Run does to me. It speaks to me in my past practice and says, hey, this is repeated everywhere. It's not just Ohio. It's not just Muskegon County. It's not just Zanesville. It's not just Coal Run. It's all around us. And it points to a way that we can have things work better than 48 years in a discrimination civil rights complaint. We don't have to go there. I'm glad we have those mechanisms, but they're not the only way to get us there.
Well, it's certainly a very powerful reflection. I think, Matthew, that we, those of us who worked in government, look back at some of that work and just see how many points at which we've had a somewhat blind perspective because of the way that things are driven from within the government, within the political system. So I'm going to pivot to another way of looking at this and ask you both. So what are your thoughts about how to provide the best resource when community-led change is really is really what needs to happen, when the community needs to define what the strategies are, what the opportunities are? How do you work in service with community-driven, community-led movements?
I mean, I think in a way, the answer to the question is also embedded in the question. It sort of starts from a fundamental sense that public health challenges are frequently, not exclusively, but frequently community determined and driven. And public health practice in, local public health departments, large public health departments are frequently focused on communities, but don't and want to engage with and convene community members and leadership and bring them into the work in a collaborative fashion. And those opportunities occur, but sometimes there are limits, right? Because health departments are constrained by limited resources or time, and so part of our goal here is to really center the idea of public health departments, public health practitioners, and people living within communities as part of the same network, right? And the health department serves as a central space for convening different actors, but it should also be understood as a place where people can go and initiate relationships and build relationships and help to mobilize efforts and actions and change around particular issues.
So let me give you a somewhat similar story that is in play right now that's offered up by one of our attendees. In Adelanto, California, there's a south side and a north side. The residents call it new and old Adelanto. The south side is clean and nice. North side is almost all black and brown, is run down, has bad water in the streets. The city has rationalized this, saying that the south side is closer to the neighboring city, which is a metropolitan area, and that's the reason for the stark differences. They say they can't fix the streets because the water problem is going to it's going to take 10 years to change the pipes. So, what do you think is an appropriate approach in this case where it seems clear to the residents, or to many of the residents, that race is really a fundamental acting factor here?
It's a challenging process. I mean, I think part of what Sam was talking about is just this idea of community engagement and listening, and being intentional about the listening. And Sam talks a lot about meeting people where they are. And I think that's psychological. I think it's emotional. And I can tell you in public health practice, it's physical. Like, you go where they are. You're going to have some meetings. You want to hear from people, go to them. And be open to what it is they say. So that's the first step. I think the second step is we all have to recognize that we think we know, but we may not. And so this idea that there's some kind of cause that, oh, it's closer to the city, oh, it's this, oh, it's that, I think there were a lot of theories about why asthma was concentrated in certain areas. Oh, it's bad housing. Oh, they don't have enough money to keep their houses. It's just a poverty issue. And boy, did we learn a lot when they started overlaying the redlining maps with asthma density. And we learned that, oh, maybe there's actually a cause that's decades and decades old, a contributing factor, a significant contributing factor to why asthma is concentrated in lower income, predominantly communities of color. Because those communities were subjected to finance mortgaging redlines. And the people in those communities were not able to get loans. And so you had white neighborhoods that were outside the red zones, able to accumulate wealth at far greater rates, fix up their homes, keep them in good condition. It helps the property tax base, it helps education. So sometimes when we think we know, we don't. And we have to challenge all of our assumptions. And part of how we can do that is through research. That's what we do in public health, we research it. I think what we bring to the table now is the ability to look at the very specific, nuanced attributes of policies and laws, turn them into data, and start to look at the impact on health, look at the impact on systems. So that's one approach. That's actually a couple of approaches. Listen to the community, start to look at laws and policies that may be in place. And also, I think, within public health, we recognize that, let's take masks. We know masks are not 100% effective. We know vaccines are not 100% effective. We still recommend them. And part of the reason we recommend them is we put layers in place. Stay 6 feet apart, wear a mask, get a vaccine. Individually, each one of those interventions is not necessarily 100% effective, but collectively, they have a huge impact. And I think we need to start to expand our thinking out to community-wide interventions and say, yeah, okay, so what if it takes 10 years? It's not going to take all 10 years to do all the houses. And isn't that a lot better than 48 years? Let's say it takes 10 years. Is our job to reduce health inequities? Is our job to reduce health disparities? I think so. And I think if the answer is, well, that's going to take a long time. Well, a lot of stuff takes a long time. It doesn't mean it's not the right thing to do. And it doesn't mean that you start to have incremental benefits over time on your way to reach some magical goal. I think one of the things that we're starting to talk a little bit about a little bit more, and we didn't really hit, is, you look at that 48-year process and then having to sue. That's emotionally exhausting and emotionally traumatic over generations. 48 years is a couple of generations. And so if we start to heal that now, you have benefit now. You may get a water line in 5 years, but you've been made part of the process. You've been listened to. We've come together as a community. We've created a consensus solution, and we're working together now, which has a benefit now. And there's going to be another benefit tomorrow and another benefit after that. Again, it's back to that point. It's like, what if these communities had taken a different approach in 1954? How would they have changed? And if they had started in 1954, they might have been done by 1956. Because as we see, it cost $700,000 in about 18 months to actually fix it. But that process took 58, 59 years. So that's kind of my thoughts on it. But, that gets a little my punk hackles up. Like, we just got to start somewhere, right? Sure, but we've got to start somewhere. And I think starting with community engagement and fundamental root cause research is a good place to go. And push back on it's too long, it's too expensive. I'm going to tell you how many times I faced that. Different issue. How many times I was told inside my agency, by my immediate supervisors, by the entire agency, by people on committee, by people at the State House, that running sewer lines to this neighborhood was too expensive. And I kept going back to the point, like, yeah, but we made a mistake and it's the right thing to do. That was the end. That was it. Okay, that's fine. Find the money. You get it. $18 billion budget, right? There's some money there. Let's find it. Let's help these people out because we messed up. Even if it takes a while, even if it's not this year. If I'm late this year, I'm going to come back next year. I'm going to keep going. So there's always obstacles, and there's always ways to get over or around the obstacles, in my opinion.
So I want to add a little note from the public health practitioner point of view. You're working for a health department, and you're kind of wondering about that fine line, that public health can sometimes, when you're in a position, you sometimes feel that if you are getting engaged in policy advocacy, that you're going to be called on the carpet for lobbying. So how would you go about giving people suggestions for understanding that fine line when promoting health policy or change?
Sam, you want to take that one? I've got thoughts on that.
Why don't you start, and I'll add to your comments.
Yeah, I guess in the big picture, with a couple of years under my belt, in the big picture, we can do a lot more than we think. And I think particularly when we look at the arc of history in public health, and public health used to have a lot more political power than it does today. Part of that was that health boards were much more widespread than they are today. I think one of the ways that we deal with this gets back to community engagement. If you have the community on your side with data, with listening, with proposed solutions, you can go a long way with that. On the more technical side, there is a difference between advocating for people's health and suggesting evidence-based solutions. It's a big difference between that and saying, city council, county council, we would like you to pass a particular ordinance that has these words in this order. In many jurisdictions, that's going to be considered lobbying to the legislative branch, may be in violation of agency policy, could be in violation of local ordinances. You need to get some legal advice about that one. But that's where I think, you know, I think over time, and I tend to think to some extent, this has been put on us by people who don't want change. But I think the lines between these kinds of activities have been blurred to confuse us. And so part of my suggestion is to unconfuse yourself and to look specifically at what it is you're doing and look specifically at what people say you're prevented from doing and see if they're the same. And then see if you have specific policies at your agency, specific ordinances within your local jurisdiction, specific laws at the state level that prevent you from doing what the 10 essential public health services say we are supposed to do, which is gather data, understand data, analyze it, translate it into action. Sometimes that's policy, right? You look at the 3 fundamental services, the 3 of them, one of them has all kinds of stuff to do with policy. So gather data, understand data, translate data into action, and pursue the action. And I think when we put it into that public health approach, we start stepping further and further away from this sort of mythical boogeyman of advocating or lobbying. Those are my thoughts.
Sam, what do you want to add to that?
Yeah, I mean, I think the other piece of it is if you think about all those pieces together, and you think about public health practitioners looking at, examining, studying laws and how they are implemented, by engaging in that study and then tracing the way that they have an impact on health, that gives you a profound arsenal, right, for engaging in advocacy for health, right? You're essentially collecting information and that is necessary for understanding why particular communities or particular populations are living in the conditions that they're living in, why their health is being harmed. That is a fundamental task of public health practitioners. And by engaging in that task, even if it means talking about issues that have political implications or seem a bit messy politically, you know, you're doing your job, right?
I think another interesting aspect of it too, which we haven't really written much on, but I think about a lot is, you know, when we focus on the data and say we present this. So if I'm presenting to a committee or subcommittee at the legislature, I'm talking about laws, or I'm talking to, say, a group of coroners or medical examiners in South Carolina. I'm talking about the laws that govern what they do. I'm meeting with sheriffs across the state to talk about the laws that authorize them to assist public health in its efforts. by focusing on the law and the systems, I'm dissociating it from individuals and people. It's not about you, even though it may be. It's not about you. It's about this other thing that has been created, sometimes decades before, by other people. So let's systematically look at this and talk about it, because this is just a collection of words. It's not you necessarily, it's a policy, it's a this, it's a that. And we can take this apart and look at it and see what it does and what it doesn't do, and what impact it may be having. And I think part of what centering these conversations around law can do as we pursue health equity is give people a little bit of space. It externalizes it from them a little bit and can make some folks who might be otherwise uncomfortable to talk about these things, gives them a little bit of space in which they can be comfortable and bring awareness to them. I did a presentation in a Midwestern city a couple of years ago, and we were talking about all this stuff, social determinants of health and things. And there was somebody there who worked for another agency, not public health, but another agency. And it was an agency that had to do with housing and development and zoning. And afterwards, in the resulting conversation was, this person's mind was opened completely. Like, literally, like, I never thought about it that way. I never thought that our ordinances might be having impacts on people's health. And the important thing to me was she was not talking about what she was doing at work and what she was doing as a personal emissary of these policies. It was about the policies. I had no idea. That's so exciting. I didn't know we could get in and look at those things and study them and see the impact that they were having on our community. That's so cool. And that to me was a big moment in my practice to say, look, if we start talking about folks' policies and laws, it gives people a little bit of space to look critically at what may be happening in their communities. We're not attacking them personally or saying they're racist or whatever. They may need to do their own work. But if we start that conversation at the law and the text and the narrative these texts create, I think we can go a long way to increasing the size of this audience of folks that we can talk to and work with to make progress.
Thank you for that. So one of the things I'm getting from a lot of audience members is that they would really like to be able to access more tools and more of the things that help to structure their conversations within their own processes, within their own governments, or within whatever their domains are. But here's a nice comment here. I love the pathway. I sit on the Board of Health in Omaha, Nebraska, and we recently began discussions that mirror the pathway that you shared today. Do samples, toolkits, checklists exist that can guide communities through such a process? One example brought forward in our work was the Kerner Commission report of 1968. Anything more recent?
Well, thanks for the comment on the pathway. And Sam's worked on that for a long time, and I have a little bit on the side. So there are tools. The pathway is going to come out. You can certainly reach out to us. I mean, we provide technical assistance to communities, have these conversations, help folks, sort of think through things, talk through things. And I would say too, and I'm recently doing some other research. There's a group, if you Google Center for the Study of Social Policy, and they have a race equity impact assessment. And it's pretty flexible. It's focused on family issues, but it's a pretty flexible framework that I've looked at. That can be really useful. Seattle-King County also has an equity impact review process that they use to look at policies, practices, implementation. There's a group called Change Lab Solutions out in Oakland. They've recently published a guide to equitable enforcement. That's really useful to really get in and dig into how you conduct your enforcement as a local public health agency or government agency. So there are a number of tools and resources out there that I know of. I'm sure Sam probably knows of others as well.
So I would recommend also taking a look at Change Lab's solutions blueprint for equity. I want to say there's also a recent sort of analysis of housing policy broadly that was put together by Temple University, sort of equitable housing policy that I think is really interesting because it sort of situates housing as a helpful study for other social determinants problems. NACHO, which is another partner of ours, does a lot of work on health in all policies and works with health departments and jurisdictions around the country to sort of do some brainstorming about their particular context and how health can be situated in relation to other social and policy mechanisms within their communities and jurisdictions. Thanks for that, Ellie. Another important point that we should highlight is that we've got a bunch of trainings on some of the law and public health topics that we've talked about here today, but others, just sort of looking at the relationship between law and public health, and that's through the Public Health Law Academy. If you Google that, it will come up on, it will bring you actually to our website. If you also go to our website, the Public Health Law Program at CDC, you can find the Public Health Law Academy there, and there are a number of trainings on the intersections of public health and law that are relevant for your purposes. And please reach out to us. Like as Matthew said, we do provide a lot of technical assistance. We're in a lot of conversations about the pathway itself and how to begin to build more tools that can sort of flesh out some of the elements of the pathway for public health departments.
Yeah, so clearly the tools are really very important because they help people to proceed. But before you can proceed, you need to have some better sense of both the context and the possibility. And so these conversations are really, really important. I'm going to give one more comment from the audience before we start to close up and see what kinds of thoughts you have. What kinds of examples might you give about how to move beyond public health in order to affect those agencies, impact the work of those agencies whose work has public health impact? For example, the ones you already gave, roads and infrastructure, policing, or safety, have huge impact on access to healthy lifestyles. Obviously, partnerships are key, but public health sometimes can, and sometimes public health can help to shift that focus. But how do we help to move that conversation forward? How do we get these other sectors and other parts of communities to engage in a discussion and engage in work that moves the public's health forward when they don't necessarily see it as being their primary task?
That's a great question. It's a challenge, no question. I think I've seen communities do it in different ways, bringing in outside folks to talk about some of these issues can be a catalyst. It's been a catalyst in a number of communities that we've been to, and sort of bring outside folks in and then sort of talk about some of these issues. And you invite folks from across local government or other agencies at the state government level. You can just convene around a particular issue. I know there's been great strides made, for example, in community involvement and cross-sector coordination on the opioid epidemic. So you can hone in on a particular issue and convene from the perspective of health. Another area where this has been successful at the state and local level has been in emergency preparedness. So it's a focused issue, but it's an issue on which not any one single particular sector or discipline or expertise can bring a solution. So using that convening power, I think, is really important. I think it starts, though, inside your agency. Ultimately, it starts with you personally. And all of us need to do work on what has racism done to us as individuals in, living in this society, some of us being raised in this society, being enculturated with the ideas that the society has been seeped in for generations. Got to start there. I shared the story about some of my past activities to say, I didn't know. I didn't know. I didn't see it because I didn't know. I hadn't done the research. I hadn't done the reading. I hadn't done the own introspection. And from there, it goes to your staff. And, if we want equity in our communities, we have to have equity within our own organizations. So diversity, inclusion, equity, all of that, hiring practices, who is sitting next to you, not just out in the community, but like literally, who's sitting next to you? Who's your colleague? Where do they come from? What are their experiences? And how are they different than yours? What's their area of expertise? How is that different? And then channeling that up through leadership and having leadership commitment to these ideas, I think, is also critical to getting wider community support and engagement.
Just a quick note, I know we're short on time, Carmen, but another thought that comes to mind about that is the kinds of conversations we're having in public health, they're going on in other spaces. And the one hope that we have is, I bring her up a lot. My sister is a transportation planner, and she comes to me a lot and she says, well, what's the public health perspective on this issue around pedestrian safety or roadways or, bus usage? And I think that to me feels like a rich starting point, right? Because that's the kind of thinking that is happening in lots of sectors and that needs to continue to happen. And my hope is that within public health, we can begin to show lots and lots of sectors the public health perspective on how we move work forward to improve everyone's health.
Well, I want to thank both of you for such a thoughtful presentation. We have so much work to do in this area, and I know that we intend to continue these conversations about what we can do working with public health law and thinking about public health law as a part of our practice. If you can go to the next slide. I want to let our audience know that applications are open, being taken now for the National Leadership Academy for the Public's Health. And I just really recommend that even if you're not considering applying, that you take a look at the program and see if you know anybody who you think, or any community organization that you think is ripe for becoming a part of our cohort. This is really about agile leadership, and agile leadership is exactly what Sam and Matthew have been talking about today. You need some information, you need some knowledge, and you really need to pivot with the change that comes, that is the challenges that are put before you. Next slide, please. And also, if you would save the date, on the 9th and 10th of November, we're going to bring the the National Overdose Prevention Leadership Summit to you. And if you would just take down this website, overdoseleadershipsummit.org, and keep your eyes peeled for when the tickets go on sale, which will be any day now. The idea here is to really try to address the issue of overdose prevention from the standpoint of opioids and multi-drug use, and how do we get all the sectors that are engaged in solving these problems together to try to figure out how we do better leveraging each other's authorities and domains. And then finally, the last slide is we're coming back to law and health equity. On the 23rd of September, we'll be talking about a pathway for moving forward. So we're not done with you guys yet. We're really thankful that you are so available to us, because this has been a really good series and people really want to hear more.